Please, Dr. Shanei.
Thank you very much, Dr. Saeed. Thank you, the organizing committee, for having me in this conference. So today, I'm going to just elaborate some points in the frail patient. What is the frail patient? I have no disclosure for this presentation. And I would like just to emphasize that not all frail patients are really elderly in this discussion. I would like also to highlight the blood pressure target treatment priorities in hypertension in the frail patient, as well as how we learn skills in treatment of this group of patients, and what challenges we are facing in treating these patients. So hypertension history or the blood pressure measurement, it is not a new for the human being. It is a long time ago, since the 1677, when the manometer was invented by this English clergyman. So one of the breakthrough news in the hypertension and blood pressure was this article, which was done by Frederick Mahmoud, and he was saying that the Bright disease, which is now called the chronic nephritis, is not a disease of the kidney. It is a disease of blood pressure that affected the kidney. And he said the blood pressure, which he calculated in 1 ounce and so on, that's the main problem which affects the kidney, and not real a disease of the kidney. Then after that, we know the most important change in the human life for understanding blood pressure was by the invention of Korotkov sounds, which was in 1905, when was introduced by the Russian physician. After that, there was also an incident happened for the President Roosevelt while he was doing his talk, and found he has blood pressure of 300 over 190. Then he passed away due to sudden collapse in the stage. The time journey for the hypertension after this incident was like more than any other disease you can find a trials and study which was done for hypertension. In every year or every 4 years, you will have like 3-4 trials till now. Now, this is a statement by the Fiona, who is a BMJ editor, and he said the controversy about how best to diagnose and treat hypertension in adults is still alive and well. And I can say in elderly patients it is more as well. So this is an article in 2003, which was like focus and highlight in special review for this kind of patient, whether there is an aging of the cardiovascular disease match the real age number of a patient. So after that, you can understand from this diagram, which is in this article, that there is, don't know the pointer, you can see it. So that's the clinical practice threshold. When the cardiovascular system becomes an aging, it is not dependent on the age itself. But sometimes you might have the cardiovascular system aging before the time, and the patient becomes frail at younger age. So we will come to the concept that cardiovascular aging versus natural age. And going back to the risk of the risk of hypertension with age, and this is the data from the United States. By 2050, 7.4% of all population will be above 80 years. And from this population, 47%, almost half of the population, will be hypertensive. And we know that it is 75% of those who are more than 65 nowadays are hypertensive. So lifetime risk for developing hypertension is more than 90%. And the older individual need higher blood pressures to maintain the perfusion, especially to the brain. This concept, we learned it for a long time ago in our learning in the internal medicine, and we don't know is it correct or based in evidence. So I will try to show some of these evidence. You can see here that with advanced age, the incidence of hypertension increase for sure, and until the age of 50, both systolic and blood pressure, systolic and diastolic, will increase. But after that, with the arterial aging, you can see that increase in the blood pressure is the end result of all the arterial aging, and which is associated with cardiovascular risk. And we know that it is called a silent killer because most of the patients will develop eventually cardiovascular disease, stroke, and MI. So these are the group of the patient that we are talking about, maybe more than 80 by a number, or by the cardiovascular age itself. So if you see here, the age is just a number, whether it is like interacting with the biological age or with the chronological age. And luckily, early in this year, we have this document that is like a shared document from a lot of associations and society, which focus on the frailty in cardiology definition and all of this stuff. Also, there is another, which is by the Benito's group, which is in 2019, also focus in the management of hypertension in older. So I will spend the remaining talk just focusing and taking from these articles. So frailty, it is multi-dimensional, multi-systemic. It doesn't depend only in one system of the body. And you can almost all the time, you will have overlapping condition between frailty, multimorbidity, and disability, and make it difficult for the physician to choose and to classify the patient. Not like the aerial patient, which Dr. She mentioned before, we have the score and you just put the score and calculate it, then you prescribe your medication. And you can see here the component of frailty is a lot. Now, this is a score, just try to divide the frailty of the patient based on the clinical, based on non-clinical, hemoglobin, albumin, and all of this stuff. And I remember one of my professors in the College of Medicine, he told me, if the patient or the person can sit up from the chair without help of his hand, this is a fit patient for a surgery. Or if he used both hands to get out of chair, this is not like fit or something like that. But now we have a lot of like scores to calculate for such patient. And this include general practitioner, doctors, nurses, and all of this stuff just to define what is frailty, and which ended by a lot of complication if it is not calculated very well. So in very old patients, we have this phenomenon, we call it the reverse causality. So in some patients if we go down with the blood pressures below the target or to the target which is written in the guidelines, sometimes you will end it with more mortality. That's why we need for antihypertension treatment might decline over time. And patient may be like off antihypertensive medication, or you will start antihypertensive medication in this stage. Unfortunately, in this group of patients, we have a lot of like challenges. One of them is the postural change. Like you can see here in this, like old Baba, he is sitting, taking his medication, then he stand up and he collapsed. So that we need to focus very well for such patient to look for the frailty, and we don't have a lot of studies in this group of patients. Only observational studies that below 130 are associated with higher mortality. The hypothesis behind this is that tissue hypoperfusion in the elderly patient is affected by the blood pressures. And this is the clinical frailty scales. I will not spend time in describing it or mentioning it because it is huge and depends on a lot of factors, including clinical and paraclinical. But the easy way, which we call it the activity of daily living, including the eating, like doing the in-house work or going to the grocery, all of this is very important in assessing the frail patient. And based on this, we divide them into three groups. One of them who lost the function and the activity of daily living, and those who preserved function. Those who preserved function, we usually treat them as a normal, like based on the guidelines. And the other hand of the table, we treat them very conservatively, and we don't go down with the blood pressure. Now you might have a patient who is, or a person who is above 80, but still he can do exercise, he can enjoy his life. And based on this landmark trial, which is the HYBIT trials, you can see that the age of the patient incorporated most of them above 80, and the treatment of hypertension was associated with less risk of cardiovascular comorbidities. in the conclusions that it is beneficial to start a medication for such patient with the following recommendations. As Dr. said, that there is a lot of guidelines in the last 5 years, but most of them did not incorporate very well the target for the elderly patient. But the therapeutic range for this patient usually is very important to decrease the event for cardiovascular event. And the over-treatment you can see here also is associated with increase the cardiovascular event because of what we mentioned before, the hypothesis of hypoperfusion. Now, the target for blood pressure above 80 depends on the other comorbidities, but you start usually if the blood pressure is 160. From 140 to 160, there are different opinions in starting or not starting based on the comorbidities of the patient and frailty, as I mentioned before. Lifestyle is not usually applicable in such patients, especially those who are have dementia, those who have loss of appetite, and a lot of comorbidities that preclude us from doing this. So when we go to the drug therapy for such patient, this is the summary for it. We started with a single drug and start low and go slow. AC inhibitor and ARBs, calcium channel blocker, and thiazide are the preferred first line unless contraindicated. And we have a caution for the combination therapy for such patients. It is recommended in all young patients, but in elderly patients, combination therapy is not recommended because you cannot, if the patient developed any complication, you don't know which drug you will blame for this complication or for this side effect. That's why we will be in this. So the main challenge for such patients is the orthostatic hypotension and the comorbidity, the adherence, the polypharmacy, and the adherence is a major major challenge during treatment of such patient. And from each 100 prescriptions, only 15 to 20 are refilled and prescribed for the patient. To solve this issue, usually we give the patient this medication box and be filled by the home sitter and filled for the whole week to give the patient easy to take the medication. Orthostatic hypotension, the hypothesis behind this phenomena is the baroreceptor dysfunction, which lead to drop of blood pressure during standing and fainting. And it is associated with the cardiovascular mortality. And some they said if the blood pressure is controlled, this orthostatic hypotension actually improved if the blood pressure is controlled according to the guidelines. So orthostatic hypotension is a drop of blood pressures 20/10 with 3 minutes standing. And we are focusing in the neurogenic orthostatic hypotension in frail patients more than the other side. One more important thing for treating hypertension in the elderly is that we mentioned, as Dr. mentioned before, the technical aspects and also how we deal and check blood pressure for our patient. I was doing my clinic today, and there is a lady came from the parking, and she told me, please don't check my blood pressure now, because I'm sure it will be high. Then you will increase my blood pressure medication, and I hate this medication. So always keep in mind while checking blood pressure for the patient to follow the technical and the clinical recommendations. If the patient rested and start the blood pressures, and for the elderly patient, the recommendation is more for the ambulatory blood pressures, more for the home blood pressure monitoring than to do in the office. In conclusion, single medication is better than combined medication for all the frail patients. Long-acting medication with predicted effect is more effective, and usually start with low dose and go slow for such patients. Age should not be a barrier for treatment of hypertension. Close monitoring for orthostatic hypotension, including the ambulatory blood pressure monitoring, is recommended, and follow-up of the adherence of the patient as well as the laboratory check for such patient. More important for me, for such patient, we need to classify them. Is this patient need a home health care or no? Because sometimes in some health facilities, they have good home health care and they can follow the patient very strictly. So if you have these facilities, it is easy just to recommend the proper target blood pressure medication. And thank you very much for your listening.